Hello, I hope you are having a great day. I have separated out this information on inhalation drugs to make covering asthma and COPD easier. I hope that you find this helpful. This is also a pretty long presentation. Under required readings on Blackboard for COPD, you will find a list of common prefixes, words, and suffixes. I have put the suffixes that pertain to this module on this slide. Knowing these will help you determine the drug class of that compound. Inhalation drug therapy has three obvious advantages. The therapeutic effects are enhanced when they are directly administered to the desired tissue. Systemic effects are minimized in the same way. And by delivering the drug to the tissues, it relieves acute attacks faster. As a practitioner, you must match the inhaler to the patient. Simpler is better. At each visit, their inhaler technique needs to be assessed. Inhalation therapy is most often used for patients with COPD and asthma. But there are other indications such as pulmonary hypertension, HIV patients, and cystic fibrosis and bronchiectasis patients. Although bronchodilators improve emptying of the lungs and increase exercise performance, these changes do not correlate with improvements in the FEV1. The FEV1 is the forced expiratory volume in 1 second and is measured by spirometry. Bronchodilators are agents which are the foundation for symptomatic management, although they do not modify the decline in function in COPD or the changes in the structural cells in asthma. Here are the short-acting beta agonists that are used. Short-acting beta-2 agonists are considered rescue inhalers for rapid improvement of symptoms and are used to relieve asthma attacks or sudden breathing problems. They provide temporary relief of symptoms such as wheezing, coughing, chest tightness, and other breathing difficulties. They are also used before exercise to prevent breathing problems. Within minutes after inhalation, these medications quickly open the airways to make breathing easier. The most common rescue inhaler medicines in the U.S. are listed on this table. The dose of the short-acting beta agonists may be doubled for mild exacerbation. HFA stands for hydrofluoroalkane, which is the propellant in the inhaler. A long-acting bronchodilator is preferred to regular use of short-acting bronchodilators. Overuse of short-acting beta-2 agonists can lead to desensitization, I said that wrong, desensitization, greater number of exacerbations, and even death. Note that these agents are also available as nebulizer solutions, which may be less expensive but may be more inconvenient to use. Levoalbuterol has not been proven more effective than albuterol. I tend to use ProAir HFA or Ventolin HFA. Both of these have a dose counter. ProAir, though, is now generic. It was costing $60 as a non-generic, and as generic it's about $30. Short-acting anticholinergic agents are available as metered dose inhalers or a solution for nebulization. Both alone and in combination with albuterol. The combination of beta-2 agonists with an anticholinergic can be used to improve efficacy and or limit adverse effects. Short-acting bronchodilators must be included in the pharmacologic regimen for all patients with COPD and asthma, and used as needed for symptom relief. Albuterol or ipratropium can be used as they have similar efficacy. Ipratropium may be preferred due to its longer duration of action. It's 6 to 8 hours versus 4 to 6 hours for albuterol. However, combination therapy with albuterol plus ipratropium provides slightly better bronchodilation than either agent alone and should be considered when the use of albuterol has failed to provide adequate relief of symptoms. Even if used in a scheduled regimen, these can still be used as needed for relief of symptoms. Maintenance or controller inhalers contain long-acting bronchodilators and corticosteroids to control asthma and COPD. They are typically used once or twice a day, even in the absence of breathing problems. These medicines open the airways and reduce swelling for at least 12 hours. They are taken every day to control chronic breathing problems. Long-acting beta agonists are not appropriate as asthma monotherapy. They can be used in asthma in combination with an inhaled corticosteroid. Long-acting beta agonists and long-acting muscarinic agonists are first-line option for COPD patients with persistent symptoms despite use of a short-acting bronchodilator. Therapy can start with 1 or 2 long-acting bronchodilators, depending on severity of symptoms and exacerbations. Add a long-acting muscarinic antagonist to a long-acting beta agonist, or vice versa, if one does not control the symptoms. Long-acting muscarinic antagonists are not usually indicated for asthma. So for COPD, the LAMAs, as they're called, long-acting muscarinic antagonists, or LAMAs, are superior to long-acting beta agonists, or LABAs, in preventing exacerbations and hospitalizations. So they may be preferred in patients with 2 or more exacerbations or at least 1 hospitalization in the last year. Okay, the combination of a LABA-LAMA. These are used for COPD only, not asthma. For COPD, the first-line option for patients with persistent symptoms despite use of a short-acting bronchodilator is this combination. Therapy can start with 1 or 2 long-acting bronchodilators, depending on the severity and the number of exacerbations. Add a LAMA to a LABA, or vice versa, if one does not control symptoms. LAMAs, actually, the muscarinic agents, are superior to LABAs in preventing exacerbations and possibly hospitalizations. So it may be preferred in patients with 2 or more exacerbations or at least 1 hospitalization in the last year. So remember, LAMAs are preferred over LABAs for COPD, especially with 2 or more exacerbations or a hospitalization in the last year. When using any long-acting bronchodilator, it's essential that all patients be provided with a short-acting bronchodilator for relief of symptoms. Long-acting agents are given once or twice daily, whereas the short-acting agents can be given up to every 6 hours as needed. Although there has been data indicating an increased risk of asthma-related deaths in patients taking long-acting beta-2 agonists, this risk has not been identified with COPD. So to make a long story short, there's been a large study, and what it found was that the risk of death and hospitalization was associated only when patients took the beta-2 agonists, the long-acting ones, without the concomitant use of corticosteroids. And it was most common, the deaths and problems were most common in the younger populations, age 4 to 11 years, and in African American patients. So based on this huge data study, long-acting beta agonists should not be used without corticosteroids in patients with asthma. However, these risks are not associated with long-acting beta agonists use in patients with COPD. Now, despite differences in pharmacokinetics, there are no known differences in efficacy between salmeterol and formoterol, or formoterol and aformoterol, which are solutions for nebulization. In patients taking long-acting beta agonists, short-acting anticholinergic agents, or short-acting beta-2 agonists can be used for relief of symptoms as needed. In patients taking long-acting anticholinergics, such as tiotropium, a short-acting beta agonist is recommended for acute relief of symptoms. There was no evidence of adverse effects with combination short and long-acting anticholinergic therapy, but there is no reason to recommend this combination. Use of tiotropium with other anticholinergic agents is not recommended. Tiotropium is a once-daily, long-acting anticholinergic agent delivered in a dry powder inhaler. It blocks the effect of acetylcholine on the M3 receptors, resulting in respiratory tract smooth muscle relaxation and reduced mucus secretion. Similar to other bronchodilators, tiotropium has not been found to improve FEV1 or reduce mortality in patients with COPD. Overall, however, there is insufficient evidence to recommend one long-acting bronchodilator over others. So, example, long-acting anticholinergic like tiotropium versus a long-acting beta-2 agonist, salmeterol. Beta-2 agonists may produce a resting tachycardia and precipitate arrhythmias, palpitations in susceptible patients. There can also be tremors or cramping and insomnia with them. Hypokalemia can be especially common when patients are also taking thiazide and loop diuretics with a beta-2 agonist. Anticholinergic agents have mild side effects, mainly dry mouth and sometimes taste disturbances. Long-acting agents have a similar adverse effect profile and do not demonstrate improved tolerability over short-acting agents. Inhaled corticosteroid monotherapy is only FDA approved for treatment of asthma, not COPD, so that's very important. Most are dosed at 2 puffs twice daily. Most come in 2 strengths, with usually double the milligrams per actuation. They are given in ranges of low, medium, and high as indicated on the handout that you have from prescriber's letter. You do not have to memorize the dosages, but you need to know the names of the drugs. All of these are approved for COPD and asthma, except for the Advair HFA. They are 1 or 2 inhalations twice a day. Remember for asthma that a long-acting beta agonist must be in combination with an inhaled corticosteroid and not used alone. Advair Discus is now generic but still not cheap. It's around $160 as a generic. Combination inhaled corticosteroids with long-acting muscarinic antagonists and long-acting beta-2 agonists. There is one combination called Trilogy, and you can probably hear the jingle in your head about Trilogy. It's easy as 1, 2, 3. But you can consider this combination for patients with severe or very severe COPD with continued exacerbations despite the use of a LABA or LAMA. The effects of corticosteroids by any route of administration are much less dramatic in patients with COPD when compared to patients with asthma. This may be because pulmonary inflammation is not prominent in COPD, or that the specific subpopulation of patients with COPD most likely to benefit from steroids has not yet been identified. That doesn't mean that you shouldn't use corticosteroids, you just aren't going to see as dramatic of effects. Although short-term use of oral steroids is effective for patients with acute exacerbations of COPD, long-term use is not recommended in patients with stable COPD. Patients who receive long-term oral corticosteroids can develop steroid myopathy, osteoporosis, hyperglycemia, as well as other complications such as pneumonia. Therefore, given the lack of efficacy and risk of side effects, long-term oral steroids are not recommended. Now, inhaled corticosteroids should be added to inhaled bronchodilators in patients with COPD with frequent exacerbations in an effort to improve outcomes. With inhaled products, adverse effects are typically limited to candidiasis and dysphonia. This can be minimized with patients rinsing their mouth after each use. With high doses and long-term use, patients can develop skin bruising. In other cases, cataracts and reduced bone mineral density have developed. However, patients taking these high doses of inhaled corticosteroids may also receive frequent bursts of oral steroids for acute exacerbations, and this may confound the actual risk of systemic adverse effects with inhaled corticosteroids. Studies have indicated a statistically and clinically significant increase in the diagnosis of pneumonia in patients receiving inhaled corticosteroids alone and in combination. But it was not shown in patients just receiving long-acting beta agonists alone. This risk was confirmed in a large meta-analysis of 18 randomized control trials and nearly 17,000 patients with COPD. Inhaled corticosteroids increase the risk of any pneumonia and serious pneumonia, but did not increase the risk of pneumonia-related mortality. Monotherapy with an inhaled corticosteroid should be avoided in COPD, but can be used in asthma. Monotherapy with a long-acting beta agonist appears to be safe in COPD, but not in asthma. An inhaled corticosteroid, alone or in combination, may be harmful for COPD due to increased risk of pneumonia. Combination therapy offers little advantage in reducing exacerbations of COPD and should be reserved for patients with severe COPD. Just a note on oral beta blockers. It's a medical myth that beta blockers are contraindicated in patients with COPD. In a Cochrane database, they concluded that there were no significant adverse respiratory effects with cardioselective beta blockers in patients with mild to moderate COPD. Therefore, patients taking non-selective beta blockers should be switched to cardioselective agents, such as atenolol, bisoprolol, or metoprolol. Since atenolol has a meta-analysis data suggesting a lack of benefit, the preferred beta blockers in this situation would probably be metoprolol or bisoprolol. Additional data suggests that beta blockers decrease mortality and exacerbations in patients with COPD, even in the absence of cardiovascular disease. Poor adherence with asthma medications is very common. It's estimated that 50 to 90% of adults and children do not take their inhaler medications as prescribed. Notice that both the unintentional and intentional contributory factors both contain cost. As I've mentioned earlier, inhalers are quite expensive. Here are some screening questions to ask. Do you find it easier to remember your medication in the morning or in the evening? Would you say you are taking it 3 days a week or less or more? Ask them to bring in their inhaler at every visit so you can review their inhaler technique. But also look at their prescription date, label date, and dose counter. Unfortunately, many of the labels are placed on the box for the inhaler rather than the inhaler itself, so making dates inaccessible. This is a synopsis on inhaler training. First, you must choose the appropriate inhaler. The patients must be educated with demonstration and return demonstration. On the next several slides, I will be going through the different types of inhalers, and there are links for YouTube videos, and I will post them below this spot on Blackboard so that you can access them off the slides. I am reviewing the most common inhalers on these slides, but not all of them. These are the steps for the use of the metered dose inhaler. Be sure to review the video and know the steps for each type of inhaler. A spacer is used for persons who may need to improve coordination between delivery of the medication from the inhaler and breathing it into the bronchial tubes. A spacer also reduces the amount of medication that settles in the mouth and throat, thus reducing the risk of thrush. A spacer is more often used for a child or older adult. And these are the steps for a metered dose inhaler with a spacer. Be sure to review the video. These are the steps for the use of a dry powder inhaler discus. Be sure to review the video. Here is the directions for the dry powder flexhaler. Again, be sure to watch the video. The next two slides compare the metered dose inhaler, that's with and without a spacer, and the dry powder inhaler. So look these over. Here are the steps for a soft mist inhaler. Again, be sure to watch the videos. Thank you for your time and attention. I hope that you have learned something new about COPD and asthma and their treatment.